I'm Bridget.
And I'm Debbie.
And we are two of the community diabetes specialist nurses. And we were asked to just talk a little bit about our service, which hopefully you're all aware of. So primarily, we are providing specialist clinics and appointments, direct patient care for people with diabetes. In the community, it's mostly patients who have type 2 diabetes. Oh, sorry, does it need to come a bit nearer? Sorry. So the main two aspects of our role, first of all, is with direct patient care, seeing patients in community, particularly those who've got type 2 diabetes, really aiming to help them understand their diabetes and working towards the self-management of their diabetes. That might be in clinics that are face-to-face or by telephone. We can come and do joint consultations in GP practices if that seems appropriate for that individual. We'll obviously visit housebound patients if they're unable to come to us, or if telephone clinics don't work for whatever reason. And our aims are just to establish a plan of treatment for that patient, and then hopefully hand over back to you with a clear plan of how we would like to get them to continue to look after their diabetes. If people are unable to self-manage, then that plan is obviously directed more for you to sort of support them to follow, really. The second part of our role really is in providing support and education, trying to raise that awareness, and trying to find different ways that we can sort of be of help to you in managing those patients. We do try and put on some regular educational sessions. We'll mention them at the end. The primary care development nurses are really helpful with that, and they'll advertise for us and book everybody in for us and collect evaluations and things, so that's really good. And we also think that meeting a bit more regularly with individual surgeries, with practice nurses, GPs, pharmacists, anybody really who wants to meet with us, we're really happy to do. We find that that's a really good way of actually getting across to you what we can get across to you, and also finding out from you what's happening in surgeries and where the challenges are and where we can try and work together to make things better. We do as well like it when people come to work with us, and if anybody would like to come and join us in any of our clinics, to sort of, if you think that might be a way to gain a bit of extra knowledge or understanding, or just sort of like see what happens when they do come to see us, then that would be really good as well.
If everybody does that, we're going to be busy.
So just to say really what happens when you do that, make that referral to us. We do really prefer it if you could use the latest referral form that's available on the ICB portal. There is a bit of extra information on the front of that if you haven't sort of seen the newest one recently, sort of directing you to where some of these referrals should be made. It's much better if referrals and indeed inquiries to us kind of come on a referral form, because there's a way of tracking it. We can see what was, it's a bit clearer really than getting maybe a task or getting a message or even an email. It tends to be the best way to do that. We have a target of triaging all the referrals that come in within 48 hours. And most of the time we kind of meet that, and maybe not always, sometimes depending on staffing and things we might be a little bit behind, but generally those referrals will be dealt with within 48 hours. We can't guarantee that we'll be able to respond to other queries, other inquiries from any other source, if you know what I mean, in that kind of time scale. Once people are referred, if they're sort of more routine, we aim to see them within the sort of 6 weeks, 8 weeks at the moment. Sometimes that's running a bit longer to 10 weeks. But obviously some people we see a lot sooner than that. Sometimes we might see them that same week if it's obviously that they just need to start insulin, or that they're going to need perhaps district nurses to start their insulin with them. So those patients get seen much sooner than that. We kind of have some patients that we keep for a very long time, but really our service has always been about a short number of appointments and then sort of providing a plan really for sort of care to continue over time. So we would expect patients to see us at least 4 times, but maybe a little bit different. And obviously some of the referrals maybe we won't need to see the patient, or maybe they have come as an inquiry, or maybe someone specifically asked for an insulin dose adjustment plan, or they're just more asking a question. So those responses we should send. We do create the letter on the same day. We know it can take a little bit longer to get back to you. We do sometimes, this is just to say really, we do sometimes get some referrals through that are a bit more urgent. We're not able to sort of guarantee a response, and quite often we're not exactly the right person to ask that question of. If it's a uncertain diagnosis, if it's a possible new type 1, somebody that's deteriorated significantly, somebody who's quite symptomatic, losing weight, somebody that basically might need to start insulin within the next, that day or the next day or whatever, it is much better if that isn't sent through, obviously, as a routine referral to us. It is much better to have a conversation on the day and get hold of someone and just and get that advice straight on, because we sometimes get a bit of a panic then, don't we, when we read something that needed to be dealt with really a bit quicker. So just so that people realise it isn't sort of for urgent referrals at all. That's why we have our registrar and Dr. Gandhi as well to answer all those calls.
He does them all himself.
Yeah.
I just mentioned that particular
If anyone didn't hear that, if you can't get through, you can go through SPA, and they can usually get through to the consultant, even if their mobile phone is out of range within the hospital somewhere.
is in range.
If it is,
too bad.
yeah. Okay. I don't know what I meant then, actually.
That means that.
Is that over to you, Deb? The next bit?
So, no, there is one missing, isn't there? There we go. So, as Dr. Gandhi's had already taught, GLP-1s have caused us all out in community and in secondary care a lot of sleepless nights. My hairdresser's had to do a lot more with getting rid of the grey. It's been quite a difficult time for all of us. And what we've needed to do is slightly adjust what we do. So instead of doing GLP-1 group starts and initiations, we've looked more about how we're going to maybe see lots of people who may need insulin starts. So we've looked at groups and things like that. But what we've actually done is modify our standard insulin pathway so that we can see more people. And we've actually upskilled our outpatient nurses within practice, within the Northern General, to actually start some patients on insulin with our support, which has been quite good. It's we've not actually had as many through as we've expected to start, because a lot of these patients have not always been started on a GLP-1 exactly as Dr. Gandhi was suggesting earlier. So some of these patients have made other options, things like SGLT2s have been chosen instead. But the patients that are needing insulin starts now actually have a nice pathway to follow. They tend to be seen face-to-face each week. We have an additional 3 slots that patients can come to each week to start insulin within secondary care. They'll then also get telephoned by that same outpatient nurse the following week just to make sure things are going okay. And then would get follow-up with the dietitian and with one of us, as it would be a normal pathway until they're ready to come back to yourselves in the community. What we did also was to rationalise it a little bit more. So now we've got specific insulins we're using. We've got a plan to follow for weight management, to what doses we start on. And it's a very personalised but very structured and very simple plan to follow. And what we've thought with this is that this could be used out in community for practice nurses and GPs and people who are wanting to start insulin themselves out in community to be able to use that effectively with our support and education. So actually in certain parts of the city we have been working very closely with some of the PCNs. We've got a group of GPs and practice nurses that have been really wanting to engage and actually approached us to actually do some insulin education. So people are just wanting to manage patients with insulin more. We've been doing a lot more education on that. But people are actually wanting to initiate insulin within practice. We've actually now doing education sessions. And this pathway does help people do that really in a structured way with our support. What we found, and the people who I've seen a few faces in the crowd this afternoon, that we work really closely with out in community. And what we have from feedback is that that works really well. So we are out there seeing patients in clinics, we're out there supporting people in nursing homes and communities. But what works really well is us helping you as much as we can. And I think when we're just somebody who sees somebody in practice and not actually supporting you, it doesn't work as well. When we come out and see you in meetings, when we do virtual, when we do virtual Teams meetings, when we come out and do joint clinics, when we have consultations and just general discussions or updates, the communication is so much better. The referrals we get are always appropriate. You guys feel a lot more supported. And in general, that's been a really important part of our job that we want to do more of. Mm-hmm. Did you want to add? Sorry.
No.
Part of our role that we've been doing a lot more this last year is working really closely with district nursing teams and ACPs out in community, and that has been really important, supporting them to manage a growing group of patients that are getting much more clinically difficult to manage, because we're getting a lot more type 1 patients out in needing district nurses input. And with us working very closely with them, we've managed to reduce patient visits from twice a day for most type 2s to one daily visit with a district nurse. So things like that, when we're working closely together and supporting each other and seeing what is working between us, is really made a big difference and impact on patient care. Patients are seen quicker, patients are getting the best practice that they can possibly get. We now provide dose adjustment plans. We've done a lot of education with ACPs in community who are now actually self-managing most of these patients that are the standard care without our support anymore. But we're also now delivering group education for all district nurses across Sheffield. But if we don't know what you need, we can't tailor it properly. So we would love you to just get in touch, hopefully with her more than me, because then I don't have to answer it. But please do get in touch and let us come out and support you, have meetings, find out what you do need in your areas and what you want us to help you with. This is you.
Yeah. This is kind of just to maybe sort of summarise what we've said, really. Obviously, we would like to improve the care for all the patients out there with diabetes. We think that we need sort of for our professional development and to support everybody's development, really, of their knowledge, their awareness, their understanding of diabetes, and sort of like improve that confidence, because patients then would really appreciate that. Obviously, they much prefer to be able to come and see you and get the answers that they need and not have to ring us and try and contact the hospitals. So that's really where we want to focus what we're doing, really. We would love to have closer working relationships and improve communication. We know it's difficult to get in touch with us when just at that moment when you would like to be able to ask us a question, and we want to try and be more accessible, but that's not easy. We're all very busy, aren't we? But we do find if we meet with you on a regular basis, you hopefully don't find yourself in that position, because we've kind of covered. You know, these things we've sort of considered what might happen. We've had that opportunity to find out what's happening, to update you on things like the GLP-1s and or whatever else it might be at that time. Things are always changing, aren't they? We do find if we can meet on a regular basis, then that will really improve it. And we would like to be doing more of that, really, as we've said. Finally, just again, primary care development nurses, sing their praises. As I say, all the education sessions that we do put on the lunchtime bite-sized sessions, as we call them, not just by the DSNs, they have lots of other speakers who organise those sessions separately to us. They also keep a record of them, they record them, and they're all available on the ICB hub so that you can go and catch up on any that you might have missed off. And the last couple of slides are just sort of advertising what's most recently been available. We also did a GLP-1 shortage bite-sized session last week, so we've left that one on. The others are all sort of ones that are upcoming. The insulin education and management, which is ours. There's one there in November, there's one at the beginning of February. They're really aimed at people who either want to learn more about insulin management. It might be that you want to start an issue. It might just be that you would like more information, more help with insulin dose adjustment plans, whatever it may be. But that's what those couple of sessions are focused on. Anything else?
No, I think that's it.
Thanks very much.